Well, thanks so much for joining us today on the latest edition of Healthline 3. I can't sit back in the chair anymore. I feel like, you know what, I'm so tiny, I have to sit up, and I'm not used to this in-person interaction anymore. So I'm excited to have Dr. Barnes here. He is new to Healthline 3, and Dr. James Barnes does what is called bariatric surgery. He is a specialist in the Highland Clinic office. Is that correct?
Yes, that's right.
And tell us a little bit about what exactly is bariatric surgery. I've heard of, weight loss surgeries like gastric bypass. Is this part of that?
Right, it is. Bariatric surgery it's the same thing as weight loss surgery. Those are equivalent terms. And so we're looking at surgical options for people that are morbidly obese, which means 100 pounds or more overweight.
Okay. Who would be a good candidate for this? Well, obviously you just said those who are morbidly obese, but do age, gender, race play?
Yeah, we look at a lot of factors. The primary one is a person's weight. They have to be, and it's 90 to 100 pounds or more over ideal body weight. So we see all ranges. We've operated on people that are 220 pounds. The heaviest person I've done is 670 pounds.
Wow.
So, we see a wide range there. Age, roughly 18 to 70. We occasionally go above that a little bit, but there are some programs, a few in the country that do adolescent bariatric surgery, but we focus on the 18 to 70 range primarily. Men, women, black, white, we get everything. So.
All right. And what types of operations do you actually offer?
So we primarily do two surgeries. Bariatric surgery's evolved a lot over the years, and there have been other operations that were very prominent for a period of time, but then for either poor results or complications have kind of come and gone. So we focus now on the laparoscopic gastric bypass and the laparoscopic sleeve gastrectomy, which are the two that we now do.
Now, there's something that you do that is, I would say, unique to the type of service that you provide. Is it the robotics that you are now able to do?
Right, and that's a program we're just starting, is robotic surgery, which it's similar to the laparoscopic surgery in that you're still making the 5 or 6 or 4 sometimes little incisions across the upper part of the abdomen. But now, instead of me standing over the patient moving the instruments around, I'm sitting in the corner of a room at a console with my fingers in these little controls, and then there's robotic arms that are actually attached to the surgical instruments. And so when I move my fingers with small movements, the robotic arms inside the patient then move and mimic what I'm doing down here. And so it gives us a little better control over things. We're finding that pain is less afterwards, recovery is a little bit quicker, and so there's going to be several advantages as we start doing these robotically now.
It's so amazing to me how a robot could be that precise, that it mimics your hands, and it's got to be down to that just a small incision, it can't be off even slightly.
Yeah, and the movements are just really tiny. You really fine control with the robot, and it's so stable because there's no, not that we have tremors typically, but
there's no shaking hands.
There's no shaking hands. There's no human hands in there per se. So
and then you've got the camera that you're able to see within that little booth.
Yeah,
correct?
And we have a 3D image through the console where we sit. Where we can see everything in 3D.
Gosh, that is just so amazing to me. So I would imagine that this reduces the downtime. Let's talk a little bit about the results. What do you get after all of this?
Sure. So let's talk about weight loss first of all, because that's obviously what this is all about. And of course, it varies a little bit from patient to patient. But with the sleeve gastrectomy, we do see about a 60 to 70% weight loss of a person's excess weight. So if somebody's 100 pounds overweight, they would lose about 60 to 70 pounds. With the gastric bypass, we see even a little bit more than that, usually in about a 75% range. So again, a 100 pound overweight would lose about 75 pounds with that. Typically takes 9 to 12 months to lose the weight. It depends a little bit on how heavy they are starting out, of course. But it's a pretty rapid weight loss at first.
all of this is just because it's going to be slowly diminishing how much the person can consume and even wants to eat.
Right. And we can talk about how the operations work a little bit. The gastric bypass, I'll start with that because that's still the most common operation that I do for weight loss. It's been around a long time. It's been around about 50 years. So we have a long track record with this. We know people generally do very well long term with this operation. It's been tweaked a little bit over the years, but the basics of it are the same as when it was first developed. And so with this operation, we staple off a small stomach. So the stomach after the surgery ends up being about the size of a large egg. So it's a very small stomach. And then we divide the intestine and bring one end up and hook it up to that stomach. And so with that, we're going to bypass the stomach, most of the stomach and the first part of the intestine so they don't absorb the calories as well. So they have a very small stomach, so they're going to fill up quickly, on a smaller amount of food, and then of the food that you eat, you don't absorb all the calories out of because of the bypass part of the operation.
Very interesting. So that's the gastric bypass.
Right.
Then there's the other option, and that's the sleeve gastrectomy.
Right.
How does that work?
So with the sleeve, and the sleeve's a newer operation. It's been around about 8 or 10 years, so we don't have as much long-term data with the sleeve as we do with the bypass. So with the sleeve, we staple up along the stomach, and we actually remove about 2/3 of the stomach. So we're going to leave a little narrow tube of stomach. It's about the size and shape of a small banana, and the rest of it comes out. So with the bypass, we don't remove anything. We're just kind of rearranging in there. With the sleeve, we actually take out about 2/3 of the stomach. So smaller stomach, fill up quicker. And then the other thing that both these operations do for most people is they decrease your appetite pretty significantly. So most people, and that's usually a long-term effect, so most people are not nearly as hungry afterwards as they were before.
How do you decide which one is going to be better for a patient, or how should a patient decide which is better for them?
The ultimate decision for the most part lies with the patient. And so what we do when a patient calls, we do a weekly seminar for new patients. It's a small group, where we kind of talk about the pros and cons, the differences of both options. They'll frequently ask kind of my recommendation, what I think is the best for them, and so it's sort of a mutually agreed upon decision between me and the patient in terms of whether we go with the bypass or the sleeve. The bypass is a little bigger operation, so that means the risk of the surgery, which are very minimal with either one, but they're slightly higher with the bypass. The recovery's a little bit longer with the bypass. The flip side of that is that we tend to see a little better results with that, though, and so with the sleeve we don't see quite as good a weight loss. It's just a little bit easier to cheat with the sleeve, and so we tend to see not quite as good a weight loss with the sleeve as we do with the bypass.
All right, so the results may not be as long-lasting as the bypass.
That's kind of remains to be seen yet. Like I said, with the bypass, it's been around for 50 years. The sleeve, 8, 9, 10 years at the most, and so we don't know 20 years from now what's going to happen with that. It's still up in the air.
All right, still very interesting to me. So how does bariatric surgery actually affect other medical conditions? For example, if someone has diabetes, high blood pressure, sleep apnea, reflux disease? Yeah,
and that's a big reason for why we do bariatric surgery. I mean, there's a lot of benefits to it, and of course just losing weight in and of itself is a huge benefit, and that's what brings a lot of people in. But it's also about a person's health, and when you're morbidly obese, especially as we get older, the body just does not tolerate that very well, and so people develop frequently a lot of medical issues related to their weight, and sort of the big five we talk about: diabetes, high blood pressure, sleep apnea, reflux disease, and osteoarthritis, pain in the knees and the back, the weight-bearing joints. And so with surgery, those get dramatically better. We see a very high cure rate. With diabetes, for example, with the gastric bypass for adult onset or type 2 diabetes, we see about an 80 to 90% cure rate, meaning people are off their medications, and it's usually within like 2 days. By the time they go home from the hospital, they're usually no longer diabetic anymore.
That is amazing, just to know that a simple surgery, and it's not so simple, could actually really change all these other health factors that they could be facing. Does the insurance cover this? Because this sounds obviously very intense.
Yeah, I mean, it depends on the insurance company. Fortunately, most of them now do cover bariatric surgery. And that's one of the things when a patient calls in. That's how we start. We'll say, let's get your insurance information. We'll see if you have coverage for it. We'll call and check. More often than not, they do. Most of the commercial insurances do cover bariatric surgery. The exception, unfortunately, right now is Blue Cross Louisiana. For most of those policies, they do not cover it, but most of the other Blue Crosses and most of the other insurances cover it. And then we also take Medicare as well. So, and they have good coverage for it also.
And the big question right now, a lot of people are avoiding operation rooms or even a simple doctor visit because of COVID-19. Maybe just to reassure the public, some of the steps that your office is taking to ensure that people are safe.
Yeah, sure. And what I tell people now is it's a lot safer to come into our clinic or our hospital than it is to walk into Walmart. There's so many precautions done at the clinic. Everybody wears a mask all the time. They clean like crazy in there day and night.
Temperature checks.
Oh yeah, you can't walk in the door without getting your temperature checked and a little questionnaire they're going to ask you if you have any symptoms of anything. And so they're very serious and very careful about that. Now there are COVID patients in the hospital. There are in every hospital. Right. But they are kept in an isolated section of the hospital, and it's a specific team that works there and takes care of those folks. It's not anywhere near where we're working with surgery or anything like that. And so we have not had any issues with COVID since we're taking precautions. The other thing we do before any procedure, whether it's a scope or a surgery, you have to get COVID tested right before the procedure. So we check everybody before they come in.
Oh, that's good to know. At least lots of precautions that you guys are taking there, especially as we're heading into flu season, which is another issue that people are thinking about. Yeah. All right, once they hear all of this great information and they decide, okay, this is something that I want to do, what should a patient do next?
Yeah, so I think I mentioned earlier that we do a seminar every week, and so if somebody's interested, all they have to do is call the office, and we will check on their coverage. We'll get them set up for a seminar. I do those on Tuesday mornings every week. We keep them small. We have them spread out. We socially distance. We keep our mask on. We're very COVID careful with all these as well. And so that's the first meeting. We come in and it's a group of typically from 4 to 8 patients at a time is all we'll do. And I'll spend about 30-40 minutes just kind of talking about some of the stuff we're talking about here and about the different operations and how they work. And then I'll meet with each person individually for a little bit afterwards and go through their medical history, do a quick physical exam, and then we'll kind of come up with a game plan. And if this is something that they're ready to move forward with, which usually they are, then we'll start setting out the steps of what they need to do. All
right, it sounds like you've got everything worked out. And how long have you been doing this now? How many surgeries do you estimate that you've done?
24 years now.
Just a little bit of experience.
I've done one or two.
Just a smidge.
So I've been doing these since 1996.
Wow, so you've really seen the leaps and bounds that the procedures have gone through.
Yeah, it's interesting. The gastric bypass we were still doing 24 years ago when I started. We were doing it open through a big incision back then. This was before we were doing anything laparoscopically. We were primarily just doing the gastric bypass. And then there's been other things that have come and gone, the stomach stapling operations of a different type and lap bands and things like that. But yeah, so I started back then. I've done roughly 3,500 weight loss operations. Wow. So been at this for a while.
Yeah, I think it's very important when choosing a surgeon to do any type of surgery. You definitely want to know their background, how long they've been doing it. Not to ding any of the young doctors right now, but that is quite a bit of experience, and being able to see all the changes and now using the robotics, I would think this is exciting.
And I think that makes a difference. I mean, these are complicated operations, and there's a lot of steps. It's not just the surgery itself, it's also the workup before surgery, it's the management after surgery, and all those things you sort of learn over time.
You've probably seen so many different issues and how to manage them once the person has already been cut open. Let's talk once again about just the who would be a good prime candidate for this? I want to bring this kind of back to the beginning.
Yeah, sure. So I would say sort of my typical patient, I would say we probably do 80% women, 20% men. You know, again, in the way we look at, I mentioned 100 pounds overweight, and the way we calculate that, if you look at a quick estimate for your ideal body weight, if you're 5 feet tall, it's 100 pounds. So this is a very thin weight, ideal body weight.
Okay.
You can add for women, we add 6 pounds per inch. So say somebody's 5'4", their ideal body weight would be 124. So that can give you a quick estimate. And again, it's a very thin weight.
Who is this? Is this Barbie?
They're very thin. So people, you know, so say somebody that's 5'4", if they're around 220 or so, they're going to qualify for surgery. They're going to be about 100 pounds over that very thin ideal body weight.
Okay, so I am 5'3", and I just hit 140, which is not normal for me. I'm usually in the 130.
I'm not answering any questions about your weight.
I would take no offense to it, but I bounce back pretty quickly. If I just do a week of eating healthy, it'll drop quite significantly. So that's another question I want to ask you. These folks who have kind of hit this weight in their life, is it because they really have found that they can't do anything else? What should they do if they are deciding, you know, should I take this surgery? Should I try to do something differently?
Yeah, and people get to that point at different times in their lives. I mean, and eventually by the time they come to me, they've realized that they are just not going to be able to do this on their own. You know, by the time they see me, they've done 100 different diets, they've had a dozen different gym memberships, they've done everything. And what they've learned and what we've learned is that with morbid obesity, diet and exercise just does not work. It's a different animal than somebody that's 20 pounds overweight. It's just different with morbid obesity. And I think that's a lot of it's genetic. You know, some people tend to gain weight faster than others. You know, I'm one of these lucky people that can pretty much eat what I want and I'm not going to gain any weight. And we all know people like that. And then there's other people that don't eat an unreasonable amount of food, but they still you know, lean towards obesity. And so part of it's a genetic component. Of course, it's also diet related too, and that's a factor as well in terms of what we're eating and also what we're drinking. That's where a lot of people's calories come from, is the sugary drinks. Of course, we live in the South, so everybody drinks sweet tea. There's 1 million calories in sweet tea. So, you know, a lot of it is dietary, of course, as well.
When I think of those who are morbidly obese, when you mentioned 600 pounds, someone who is 600 pounds, 700 pounds, I would think that there is some sort of mental health aspect that goes along with that. Is that something that you do following up with them, or that you ask that they try to get done?
Yeah, and that definitely can be, there's a lot of mental factors or psychiatric factors that can factor into this as well, whether that's an eating disorder, whether that's a food addiction. We sort of deal with food addiction quite a bit.
Traumas that the
trauma can certainly cause issues with that. Depression is another one. You know, depression's, you know, some people with depression eat a lot, some people don't eat at all. There's different responses to that, but that can be. So there are definitely a lot of emotional or psychiatric factors that come into play. One of the things we do on everybody before surgery is we get a psychiatric evaluation on everybody. And this is actually required by most of the insurance companies that it has to be done anyway. So we get that on everyone. And sometimes it'll help us identify some issues that we can address. And sometimes patients will continue to follow up with the counselor afterwards to work on some of these issues. We also, or at least we used to before the world went crazy in March, but we did a support group monthly that met over in my office, and that was a great group. We would meet on a Wednesday at 5:30 once a month. Wow. Usually, anywhere from 15, 20 people, something like that would come, and it was really a great meeting. We've had to sort of put that on the back burner for a little while right now because it's just too big of a group to get together.
I love that you do that and that you mention that on air, because it shows just how committed you are to seeing that your patients don't go through this again, that they don't go back to square one, that you are committed to seeing that they are healthy and that they stay healthy, that they stay on this track.
Right, and that's such a big part of it. I mean, the surgery is important, but that's just an hour and a half in a
Yeah.
patient's lifetime. And so probably even more important is what happens afterwards in terms of the follow-up. And you know, that's why we see people back pretty frequently, especially, you know, in the first year. We work with their diet. We, you know, gradually advance the diet as they, you know, for the first 9 months after surgery. We watch very closely if, you know, the weight's not coming off like it should, what's going on, what, you know, and try to address that. You know, it's very clear the people that, you know, because, you know, unfortunately not everybody, you know, some people follow up better than others, and we do see the people that don't follow up very well after surgery are the ones that tend to not do as well with it afterwards. So, you know, we try to have a very comprehensive program because, again, the surgery itself is just one small part of the long-term success with this.
In the 24 years that you have been doing these surgeries, how often would you say you see success rates where they don't have to come back for another surgery, but they are able to keep that weight off?
So if you look at, and I'll talk about kind of national numbers too, and ours mimic that, but you know, it's not 100%, nothing is, but we do see somewhere in the range of 80 to 90% of people have long-term success with this.
Wow.
There are some people that regain weight back over time. Again, those tend to be the ones that are less good about coming back and following up. You know,
So it's
you
really
can,
in their hands.
it
They have
is
the
to a
power.
large part, yeah. And we're there to help, but you know, we can only help so much. You know, they have to do their part as well. Most people, though, this is a long-term success. And when you compare that, we were talking early about the just diet and exercise alone, and the long-term success with diet and exercise by itself is only about 2%.
All right. Well, of course, we want to answer all of those questions that the public has, and I think right now we have Jean who is on the line, and she has a question for Dr. Barnes. Fire away, Jean. Hello? Can you hear us okay?
Hello.
Hi there, Jean.
Hey, Jean.
Hi. What I have this question is on your age. I've heard that if you're over the age of 60 and you're overweight, you have this surgery, that it's not really good for long term. Is that correct?
No, it's really not. The success isn't really affected that much by your age in terms of how you do afterwards. Now, as we get a little bit older, sometimes the risk of surgery can go up a little bit, and we will frequently, in our older patients, we'll have them evaluated by a cardiologist or by a pulmonologist, and just to make sure that they feel like they're safe for surgery. So the risks are slightly higher, but we sort of assess all that before we get in there doing anything. But in terms of the success with the operation, I've done lots of patients in their 60s and 70s even and they do just as well as a 20-year-old, sometimes better, because they
Wow.
tend to be, I think people that are older tend to
taking
be a
it
little
more
more
seriously.
compliant. Yeah, I think, you know, so I think actually probably overall people tend to do a little bit better that are older.
And Dr. Barnes,
Oh.
if Jean wants to get in touch with you, how can she do that?
Sure, she can just call the office. I give the phone number out, I guess.
Yes, absolutely. I think we
I
have
don't
it
know
up
if it's
there.
up there or not, but it 798-4432, and just call and make an appointment, and we'll get you set up for a seminar if that's what you're interested in doing.
Oh, okay. Thank you.
All right, Jean, do you have any other questions for the doctor?
No, but I didn't get the phone number.
Oh,
Sure, it's 798-4432, or if you forget it, you can just call the Highland Clinic and ask for me.
Oh, okay.
all right.
Thank you
Jean.
very much. I
You're
appreciate
welcome.
your answer.
Thanks for your call.
Bye-bye.
That is interesting. I never thought about that. If somebody is, oh, we already have another caller. We have Carletta who's on the line. Carletta, happy afternoon to you.
Hi, Carletta.
Hello. My question is, once you have the surgery and the weight begin to come off, if it's coming off so fast with excess skin, what can you do about that?
Sure, that's a great question. Everybody's going to have some excess skin after surgery. That's just a normal response. Now, the skin does come back to some degree. Most people don't end up doing anything with that. You know, you may see on TV and some of the weight loss shows and stuff, they have the really dramatic patients that have all this excess skin.
Oh, yeah.
Most people are not like that. Most people have a little bit, but it's usually not as bad as they worry about or think it's going to be. Some people will go on to have plastic surgery, tummy tucks and things like that. Probably only 5% of our patients end up doing that, though. It's a pretty small number, quite honestly. So, most people, some people will wear like undergarments like Spanx or something like that will sort of help, cover things up or hold things up a little better. But typically it's not as bad as most people think it's going to be.
Okay.
Now, and Dr. Barnes, is that something that you would once the surgery is done, you would refer the patient to a plastic surgeon?
It is, yeah. I don't do any of that type of surgery myself, but we have a couple of plastic surgeons that we work with a lot, and so the folks that are interested in that, we'll get them over to see them.
All right. Carletta, do you have any other questions for the doctor?
No, that was my question.
All right. Thank you so much for calling
Thank you. Okay, bye-bye.
Thank you.
Oh, and Susan, we have a Susan on the line. Susan, fire your questions away for the doctor this afternoon. You're getting all the calls today.
That's
I think other
good.
doctors are gonna
Hello,
get
how are
jealous.
y'all?
Hey,
My
Susan.
name is Susan. My question for the doctor is, I had gastric bypass surgery, root gastric bypass surgery in 2004, and I need some revision done. Do you handle that as well?
I do. I actually do a lot of revisional surgery, whether it's from gastric bypass or other, stomach staplings or lap bands, but revisional surgery is a big part of my practice. And so the way you would handle that is just make an appointment. We don't start out with a seminar with that. We would just have you come in and I would just see you one-on-one, and we would kind of talk about what you had done, what sort of issues you're having. We'll frequently then set you up for me to do a scope on you, where I'll look down in your stomach with a little scope, and I can look and see exactly what's going on with your stomach and what the anatomy looks like and what we need to do if there's any sort of revision. Sometimes it's not surgical. Sometimes it's just, if it's a weight regain issue, it's a matter of just working with you on your diet and things like that. But sometimes there's surgical issues we can address as well, but I do a lot of that type of stuff.
All right, do you have any other questions for the doctor?
No, that's wonderful to know, and thank you, and I'll look forward to talking to your office and setting up something.
All
Great.
right, thank you so much for calling in. Well, you are getting both men and women interested in this topic. I believe we have a Steve who's now on the line.
Hey, Steve.
Yeah. Hey, my question is 100 pounds your minimum for that type of surgery? And the reason I ask is that I had a back surgery which limited my exercise activity. So my ideal body weight, according to your standards, would be like 140, but I weigh 235. So how do I get to that point where I can benefit from bypass surgery, or do I need it?
I think you're probably going to be close at that weight, and I would, we could certainly have a look at you and see. The restrictions are really kind of come from the insurance companies, quite honestly, and they're the ones that, if you fall below their threshold for what they recommend for surgery, then they're not going to cover it. But it sounds like you're probably pretty close to that mark, especially if you have any health problems related to your weight. More likely than not, you probably would qualify at that weight.
Oh, that's very interesting. So should Steve just go ahead and give you a call?
Yeah, he can just
directly?
call and make an appointment. Be happy to see him.
Yeah, I'm curious because I'm mostly muscular, except that I've gained weight since surgery.
Yeah, well, if you just call, we'll get you in, and we can decide if you're going to be a candidate or not. But I think more likely you will be.
All right, thank you.
Thank you.
All right, Steve, thank you so much for calling in. Well, we have 1 minute left, Dr. Barnes. Just quickly mention to the public once again who you are, where you're located, and how excited you are to be servicing this community.
Yeah, so Dr. James Barnes, I'm Chief of Surgery over at Christus Highland Hospital, which is where we do all of our surgery. My office is in the Highland Clinic, which is adjacent to the hospital right there. So it's all sort of in that one complex. Christus Highland is a big bariatric center of excellence, so we do a lot of bariatric surgery there. It's a great facility, a lot of new stuff coming there. I think most of our patients have a really great experience there.
All right, and 24 years of experience, 3,500 surgeries, I believe I remember you saying.
That's right.
All right, we're definitely the guy that we need to talk to, and we're going to continue to talk with Dr. Barnes. He is new to Healthline 3, and we are so happy that everybody called in today. Thank you for joining us.
Thank you
and
very
great job
much.
on your first Healthline.
Thank you. I appreciate it.
All right. Have a blessed day, everybody. We'll see you back next month. Take care.